Welcome everybody. Please take a seat, close the door in the back. I really want to get started. We have a very packed program today. Lots of stuff to tell you and share with you. We're here for the session on accelerating the path to digitally enabled integrated care. And we're sharing the best practice that was gathered as part of the JADECARE project. Maybe you can also put on the next slide where I think there will be a QR code where you can read everything on the JADECARE project. So what is this project about? I think we are all aware that we have aging populations and an increasing prevalence of chronic diseases and also a multimorbidity, which is steadily driving demand for care, especially for chronic care patients. And it needs an intelligent outcome-based delivery of personalized care. And often this integrated care is seen as the solution, the answer to deal with this challenge. And especially now after the COVID-19 pandemic, I think we all understand the urgency we have to transform our health systems. And I think we should capitalize on this momentum that is there. And I think that the JADECARE project couldn't be more topical and at the right moment in time to share some of the results. So what did the JADECARE project do? It aimed to bolster the capacity of health authorities to transform healthcare transformation. And how did it do that? Through sharing of best practices. So the JADECARE project selected 4 good best practices in the Basque Country, Catalonia, and Denmark and Germany. And they then adopted those in 21 different regions, covering more than, I think, 4 million people. It's an amazing number. The elements that were addressed in these transformations were, of course, the digital transformation, which I think was a key part of the project, but also reorganization of care pathways, change management. I think there's a lot to learn here about implementation and those processes. And also citizen empowerment, person-centered care, etc., much more. The way we try to do this today will be in 2 panels. We are not going to do long, winding PowerPoint presentations that bore everybody to death. We're going to have panels, 2 panels. In the first panel, we will hear from 2 adopters, one from Greece, Christina Plomariti, and one from Estonia, that's Mart Kul. And they will focus on their projects, but also on the wider lessons learned and the impacts that the project had. And also we'll be discussing about the blockers and the enablers of their projects and what we can learn there. Then we will switch to a higher level and have a panel with policymakers. Actually, the Minister of Health of the Basque Country, Godzone Sagardui, is here. And also a former Minister of Health of Hungary, Miklos Soska, is also here, now the director of Semmelweis University. And they take a bit more a macro approach in thinking about, how at the policy national level they can support these policies. And we will have a small panel discussion, which is led by Jelka Selatel from the National Institute of Public Health in Slovenia. We have a younger Steiner over there, Michele Calabro. He is going to take care of the chat and on Slido. So for our online viewers, do engage with us, ask us your questions. We will feed them back to the presenters. But before we go, we also have some Slido polls for you to engage you and see what you think are some of the key issues. But before we go to the first Slido poll that leads into the first panel, I would like to ask Paloma Calleja from the Ministry of Health in Spain, who was also a partner in this project, and she's the head of service of the Subdirectorate of Quality of Care, and she will talk about the impact of JADECARE joint action. So, Paloma, you can come over here and you can take the stand here. I'm now going to move down. I'm not going to get up here again. I'm going to be with you down there.
So thank you, Ewald. Thanks to European Health Forum, and especially thanks to Bios de Mar for your invitation to participate in this final conference of JADECARE Joint Action. From Spanish Ministry of Health, we would like to express our congratulations to all the organizations that have taken part in this joint action. We are convinced that the hard work and the shared effort has led to improve patients' care, as you will surely explain to us next. Spain has traditionally shown it's committed to European health programs, and thanks to an intense and coordinated work with different regions, our country has participated in the implementation of a large number of joint action over these years. In JADECARE, we have a good example of this because two of the best practices to be transferred were Spanish. Joint actions are an essential element for Ministry of Health and our national health system as a whole, and their importance goes far beyond their financial contribution. Firstly, these calls provide an opportunity to recognize the innovation and the effort of healthcare professionals and their organizations. Secondly, they provide the perfect scenario to take advantage of experience that are developed in different environments, allowing learning opportunities for each and every one of us. Finally, joint actions is a powerful tool for promoting the implementation of the actions included in our health strategies. In this context of JADECARE, I would highlight the strategy for addressing chronicity, which was published in 2012. The scope of this strategy is closely related to the aspect addressed in these joint actions, among which we can see the reorganization of model towards into integrated care, the incorporation of digital tools and citizens' empowerment. Specifically, the experience carried out by Spanish adopters have contributed to fulfill the Objective 18, which includes the promotion of technological innovation and its evaluation. The third European Health Programme identified a number of challenges to be addressed that almost 10 years later are still relevant. Life expectancies has continued to rise, and non-communicable disease continue to be associated with most of deaths and most of years lived with disability. To this, we must add the consequences of the COVID-19 crisis that has had on our population, on our health service, and on its professionals. The context, therefore, continues to demand to the European countries move towards to a more integrated and personal-centered approach, and to this purpose, digital innovation has shown the potential to facilitate this change. Some of the packages that were transferred in this joint action, such as risk stratification systems, the incorporation of digital tools in teleconsultation and home care support, and technological solutions for patient empowerment are clear examples of this. To conclude, it only reminds me to express once more, on behalf of the Ministry of Health, our most sincere appreciation for the results achieved with this joint action, and to give the floor to the real protagonist of this final conference. Thank you very much.
Thank you very much, Paloma, and it's really good to see that I think Spain really is a pioneer in integrated care, and you're still pushing further along, and you will not leave it at just this project alone, but you're going to continue on this path, and we will be watching you and learning from you and all of us here. Ed is the man with the control knobs in the back, and he's going to put up a Slido poll for us to see where you think some of the most relevant enablers are for the adoption of digitally enabled integrated care are. You can think of maybe financing, or is it skill mix, workforce, leadership. So please go to the slido.com or scan the QR code here. I know that also the online audience can access it directly next to the stream, I believe. I can already see in real time appearing some words, so we'll give it a little bit of time to have you fill out some 14 people typing. Trust, private sector. Trust is big, meaning that many people are saying trust. Money, always important, of course. Skills. I also see co-design. Really interesting data sharing, of course, which was a large part of the project. Okay, skills, trust, money, data sharing, political commitment, breakdown of silos. Ed, maybe we'll leave it at this and we'll do the next, and we're going to look at some of the blockers, and then we'll have the panel. So maybe in the meantime that we have the second slide on, I'm going to ask you, Mart and Christina, to already get on the podium. Can you do Q2, question 2, Ed? So what are the main blockers? Also skills, yeah. GDPR, skills, funds. Money, of course. Actually, so the blockers are also the enablers. Maybe we could have expected that. Money, infrastructure, lack of infrastructure, literacy, of course, really important, resistance to change. Trust, again, also an issue, but lack of infrastructure seems to be the largest so far together with GDPR. Shall we then now move into, you can close the Slido, Paul, and we're going to move to the panel. So I again welcome you, Mart Kool and Christina. I will first ask you to talk a little bit about the project, in your case in Greece. I want to start with you, Christina, that you implemented there, and which bits did you use from the best practices? And I know that you can also talk more about the overall impact of the project, and we'll get to that as well, but I think we also want to know what you actually implemented.
Hello, good morning. So in Greece, we chose the Basque country as the original good practice that we wished to extract features from. And we chose to focus on the patient stratification block and also on the patient empowerment. The main idea behind this is that Greece is just entering the digital health era with very small steps, might I add. But COVID-19 was actually the starting point for us to start digitalize our services. So we thought that it was a very good time to try and implement the stratification, because actually we started collecting digital data for the first time.
Risk stratification.
Risk stratification, yep. And also the patient empowerment, because we have, in my institution, we have identified the need for person-centered care and for actually empowering patients towards being the keepers of their own health, let's say. We have early identified this need, so this is why we also chose the patient empowerment block.
And can you talk a little bit about, did you recognize some of those enablers and blockers that were shown here?
Yeah, I did, but dare I say that I agree with all the enablers, but for us, the biggest enabler was the guidance that we actually had throughout this implementation. Because, okay, to have money, to have digital data is one thing, but if you have somebody who has done it before, the original good practice holder, to actually guide you through this journey and help you match your needs to the solutions and see what better fits, I think for us that was the best enabler here in all this journey.
So that's basically also leadership and having some local champions, or?
Yeah, but not only local. I'm talking about the way that the project itself was structured, and we were in close collaboration with the original holders, so with the Basque country themselves, to guide us through the process and help us see what they did and how we could not do the same thing, but how we could transfer and personalize their solutions in our settings.
Did you make many adaptations to the original best practice?
Sorry, come again?
Did you make many adaptations and changes to the original practice?
Many adaptations, yeah. Because, as I said, we just started digitalizing our data, so it is not possible to do the same stratification like a country who has digital data for decades, and the quality is non-comparable to ours, of course. Because for us, we just started collecting data, so we had some poor data of poor quality, poor amounts, so it was not possible to do the same thing. But we tried to work towards that. In the end, we could not actually perform the complete risk stratification, but what we could do is utilize some momentum, so move towards policy recommendations in order to actually achieve this at some point. Yep.
Okay. So maybe now I'm going to move to you, Mart. I've been to your hospital in Viljandi. Probably one of the few people actually was in Viljandi in the middle of Estonia. Can you tell us a little bit more about which project or which example project did you implement in Viljandi, and what are some of the problems you encountered, and did you also make so many adaptations? Did you see the same blocks and enablers?
Yeah. One, two.
Just speak, it works.
Okay. First of all, thank you, dear Karsteiners. It's a real pleasure to be here at this wonderful forum. Regarding our project, we were trying to implement integrated care in the Viljandi region. It's a county of 50,000 people for approximately 4 or 5 years at that time. So we were in a kind of a PDSA cycle and trying to see what needed to be changed. So what we were doing is we tried both horizontal and vertical integration with the hospital and GPs and the medical system and the social system. So we tried to find all the high risk patients in the hospital workflow that had also social health determinants, and then assigned care managers to them and made the care plans and tried to kind of keep them out of the hospital. So this was the first part of our project, but it was really labor intensive. So at that time when JADECARE approached, we saw that we needed a few more tools to find the cases quicker, because it was really labor intensive, and also we understood that we need to organize the integrated services better in the county. So JADECARE was like a very nice library of validated and good best practices in Europe, which we could kind of take like puzzle pieces and put in addition to our service. So this is what we did, and we chose the Catalonian risk stratification or case finding model, which we had to validate, of course, and which we did, and then we had to get the data from all the registries in the country. And the other practice that we really looked into, unfortunately, the time frame of the project was too short to really implement, was the Optimedis accountable care organization.
You were also during COVID, right? You had to implement under those circumstances.
Exactly. That was, I think, for all the new adopters in JADECARE, I think the timing was perfect, because we had two crises, or the project and the crisis of
which you
COVID.
should never waste, of course.
Good crisis, yeah, should never go to waste. So we had this too. We had like a mix and match approach.
Okay, so then also, how did you get the people, the health workers along in your project? I mean, that is often quite difficult to convince them to do something new and have more digital tools. I know that the Estonians are quite good with that, and they have sort of already experience, and they seem to be quite tech savvy already, I think. But still, how did you do that? And also, wasn't that extra challenging because of the COVID pandemic, that they were just so busy with that and overloaded perhaps.
That's so true. So I think the human factor or getting people on board is the most important and as well hardest part of an integrated care project. And I have said sometimes, and I think there was a trust came up as one of the main enablers. And I think integrated care is a lot like a good marriage, in a sense that you really need to get to know the other partner, and then when you know him or her or how he does and operates and what he thinks, then you can really start to trust, and when there is trust, then there probably will be integration, and you can really start changing the services, because we usually think that it's the IT systems that should be talking to each other and a lot of data that leads to good integrated care. But we tried that in Viljandi. We had 7 or 8 years ago, we did a module to our electronic medical records, so all of the GPs could see what's happening in there.
I remember.
Sorry?
I remember that when we were there 5 years ago, you were talking about this.
Yeah, so the GPs could see live what's happening to their patients in our hospital. So if they went to an ER or got hospitalized, so there was no delay, but it didn't change how we provided services. And then we thought, okay, we need to do a care plan platform, and we even installed it to the social service providers so they could see the care plans as well as the GPs. So it didn't change much how we provided services, so it didn't improve the integration. So IT is just a tool to facilitate, but I think the trust and the people, bringing the people in one room is the beginning.
I know that it's going to be music to many people's ears here, that it's still about the people and about trust. And then kudos to WHO for organizing a conference in your country, in Tallinn, which is about trust and transformation. So it is indeed, I think, a key issue here. Other than, being implementers in your own country, and now I'm returning to you, Christina, you also were in charge of a work package, and you looked at the overall impact across all the different sites. So can you tell a little bit more about that?
We actually performed a very elaborate impact assessment to the whole project level, but also to individual levels of the participants, the next adapters as we call them. I can say that, first of all, to answer the question before, how to engage the medical personnel. There were many adapters who actually launched training activities to get their workforce to actually know better the solutions that they were preparing, but also the early involvement in all decision-making of healthcare professionals also helped. May I say that, it was a very big project, JADECARE. We touched many people. I mean, in the piloting phase, combined, we had around 100,000 participants, and if you count the risk stratification, more than 4 or 5 million people stratified all around our next adapters, which is huge actually for a project to actually involve so many people and that large amount of data. So I think that, and of course, what I also would like to add is that we had the 4 original good practices, but the transfer, it was not take and use. Everything was based on adaptation, which is also very nice because we ended up with 21 very different practices based on 4 and personalized on the individual needs of every next adapter. And I think that this is a very big win here, that from 4 we ended up to 21.
And was that something you expected, or did you think, we're just going to use these blueprints and we're going to implement this?
Personally, in the beginning, I thought that it's just copy and paste.
Wishful thinking, probably.
Yeah, copy and paste. I will take this and I will take it as it is to my own setting, but because we had a very elaborate also pre-implementation phase, assessing the needs, figuring out the scope of what we want to do, throughout all this process, it became apparent that no, it is not just that you take something and you just put it in your local setting, because it is impossible.
But it was also more like an inspiration that it can be done, and then you make your own local adaptations. And
Exactly, exactly. It was, we made sure that it can be done. You can take something and actually transfer it. But we also wanted to, in the process, to see what were the adaptations that needed to be made and at what degree. Because this is always the question. Where it stops being the good practice and we're going to something totally different because the adaptations are just too many, or are we staying on the right path and just adapting a little bit?
Okay, thank you, Christina. Mart, I know that you were in charge also of a work package looking at overall lessons across all the sites. Were they very different from what you experienced in Viljandi, or were you quite, you know, a good example of what the others were experiencing as well? Or did you see things that you didn't expect or didn't experience yourself?
I think the settings were, as Christina said, very heterogeneous, and I think you had to adapt the original practices to your own context. So I think it's really helpful. We had a kind of a bottom-up approach, but I think there were quite a few new adopters who had the top-down. So I can maybe more comment on the bottom-up and the barriers and the facilitators there.
Please.
So you really, we were facing the problem. Also, the COVID was a big problem because of the resources, and they were saturated on all levels practically. So even if we try to frame the new practice in local policies and priorities, but when we try to engage the authorities or the health insurance fund for sustainable funding to continue, then usually they ask, does it cure COVID? And if the answer was no, they ask to come back in a year or so. So it was really hard to get them engaged. So it was only, I could say, during the last year of the project, when we're doing already those practical things and could show how we are using the tools, then the interest rose. And now we have been having several high-level delegations coming and asking, oh, that's how you do, that's very good. So now it's kind of getting into the policy makers more at the moment. So this was something that we learned from the bottom up.
As we are doing here, of course. So I would like now to also go to the audience and see if there are questions. Michele, do we also have activity online? Maybe you can summarize 2 questions from me, but maybe first we'll go to the audience. Is there a question? Yes.
Stefan Tomek, Equivalence Group. What is your plan about implementing artificial intelligence with big data? Do you have the right questions to them, to AI? I think the right questions are the critical point in future. Because we developed a software, for example, called Synergy Balance to control AI, which means that we question the patient and we question the AI. And then we pile and control the answers and compare it in a kind of health balance sheet. If you are interested, we can cooperate.
Are there any other questions? I would like to gather a few. No? Online, do we have questions?
Yes, I can actually try to summarize in 2 blocks.
Perfect.
One is on how did you measure evidence for patient benefits? So is this something that you did? And then there is like a group of questions on implementation actually. One, they can be summarized in kind of 3 sub-questions. So one, how do we go beyond fragmentation in implementing solutions within countries and regions? And then there's also a question on, could you give an example of adaptations made to the best practices and whether there was more top-down, bottom-up approach?
Okay. Does any of you want to take the AI question? Maybe you, Mart?
I could try. I know that at the moment we are not using AI in the risk stratification, but I guess in the future maybe the Catalonian model also evolves in a way, because yesterday we heard how in Israel, I think it was in the morning, the GPs come in and then they know what are the patients that they need to really deal with. So, but the AI, it is a very interesting tool, and I think there's going to be a big shift in how we as providers, as doctors, need to view ourselves or perceive ourselves, because at the moment we are more in the provider or the teacher role, but I think with the AI and the patients are getting so much more knowledge, and we move more towards the translator role, I think, in the future. So I think this is something we have to adapt quite quickly, and it's not taught in the medical school.
So this is also where the curriculum needs to be adapted.
Probably, yeah.
Which was also one of the enablers mentioned, I think, by the public and also the online audience. Would you like to take the question about what you found and how you measured the benefits?
Yep. I can tell you that on an impact level, we did not measure specific the outcomes on the patients, but there were many adapters who utilized PREMs and PROMs to actually evaluate their own implementation. But the time frame was very short of the project, and as said before, we also had the COVID. So it was really difficult for us. But we do know from the impact assessment and from the results that there are many next adapters who will continue the evaluation even after the end of the project, because the implementation just ended. So it is very, very soon to talk about the outcomes that actually influenced the patients. But it will come in time.
Yeah, would you like to take the question
I would,
about?
Yeah, just like to add, with the help of JADECARE and the Barcelona University Hospital, we continued the JADECARE into a clinical trial. So in the next 2 years, we'll be measuring also not only clinical or hard outcomes, but as well PREMs and PROMs and those soft outcomes. So this is now carrying beyond the JADECARE project.
Okay, but it is not that is something you do individually with your site, or is it also part of a new project?
This is our local, it's funded, it's innovation funding from the Health Insurance Fund, so it's continuing now separately from the JADECARE.
And do you know whether other sites are doing similar things? I know that, of course, you need years of data to also see the benefits. Are other sites doing similar projects to measure and see what the benefits are?
There are many sites that will continue the collection of PREMs and PROMs after the JADECARE, either through different projects, so trying to use this kind of implementation in other projects and expand it and ensure the continuation, or as a standalone effort. Yep.
Yeah, Mart?
Just another comment, because sure. I think when we're talking about the barriers, the GDPR and the data privacy or protection regulations are a real obstacle in many of the cases. So we opted for the clinical trial scenario because we could use the ethics committee approval, and overwhelming public interest was the clause there to use personalized data. So we can now go to the specific risk patient in our county and address him or her with the services we think that they need.
Okay, before we go to the question on implementation, maybe is there a question in the audience? No, am I missing? No. So the implementation was commenting on, well, you alluded to it before, I think, about top-down versus bottom-up. You said I can only talk about bottom-up because we did it bottom-up, but what do you think? Is it, or maybe you?
Yeah, because they wanted to, if I remember correct, the question was to give an example of the adaptation. So I can tell that in our case, perhaps, we saw the patient empowerment module that was introduced by the original good practice, which was actually an online school of health, let's call it, and we tried to adapt it based on our capabilities and and on scenarios that we have seen that have already worked in the Greek population. So we, instead of an online platform, we implemented a mobile application including integrating virtual patient scenarios, which we know that have been used again in the Greek population. So that was the kind of adaptation in our case. Just an example.
Would you like to comment, Marta?
I would, yes, I can comment on the top-down. I think again, one of the good things about bottom-up is you can really know the context, you know the problems in the field, and it's very important if there are those willing to implement that change, or the champions, which are really critical to spearhead and really get the GP doors open, and it's not an easy process. So with the JADECARE, we really had the library to choose. So why not there? If there was a library, and why not the field workers or the doctors there can choose the tools to implement. So I don't know how to scale such a model. It would be really fragmented because the interests would be different in different parts of the Estonia even. So,
but you do need top-down support, I'm assuming.
Yeah, that would be really important for let's say, scaling.
And that's also, of course, the topic of the next panel here. Maybe is there another question? No, I think you're very clear, apparently. I have a question for you, though, about what is your main message to other potential adopters? Maybe there are some in the room here. What is your main message to them? What should they know before they start? Maybe, Christina, you would like to start first?
Yep. First of all, my message would be to involve as many stakeholders and different stakeholders as possible. So healthcare professionals, patients, policymakers, everybody in the process of, before the actual implementation, when you are choosing what you are going to do and how you are going to do it, you need to involve as many diverse people as possible. One thing would be this, and another message from our side would be to make sure that you analyze not only the needs of your local setting, because the needs are many, but also the capabilities. Because analyzing the needs, then you see a list of good practices, and almost everything would fit your needs, actually. But also have in the back of your mind to actually see the capabilities and the time frame, and of course the money available, because this could diversify very much where you want to go and where you will actually end up going to.
Yeah, those are two very clear lessons, I think. I also really like this idea of getting all stakeholders on board, having also, I think, a shared vision where you want to go, right? So that everybody can rally behind,
Yep.
know what you're doing, and then you can implement. That's also part, I think, of building trust, probably. Yeah. Mart, maybe your...
It's really hard to add something to Christina, but
try.
I will try. So I would like to emphasize the people part of the relationship part of integrating care. So I think a very important step in our county towards integration was when I, as a head of a hospital, went one-on-one with the GPs in the county to talk to them, and it's not comfortable even for me, because I'm sitting there alone with 3 GPs and 5 nurses. So, but I ask the questions and come and ask the questions. What are you doing? What are your incentives or motives, and what are your problems? And sometimes even more important, what are your fears? So the fears were very specific. So when you do these kinds of meetings, like in town hall meeting, you don't get those. So they will. One was afraid of, I don't want a new IT platform. The other said that the hospital will take all our money, and they were very specific. And if you could address them, then we could get half of the GPs on board with the JADECARE and the new clinical trial. So it's really communicating and building trust. So I think that takes you an area or a region to integration. So I don't know how to buy that, because it's really hard for the health insurance fund to buy that, but I think it's really one of the critical.
Well, you buy the health insurance fund with data that shows that it has benefits, right? So also financially. But thank you very much. I think this was incredibly helpful for understanding what you've been doing, the kinds of challenges you have been facing. Thank you, and I think we're going to move now to the next panel. But before we do, yes, please. I will ask Ed, the man in the back, to put on the next Slido poll, which now will be a closed one, because now we're going to talk about more the macro level, the policy-making level, and what they can do to support and make these sustainable, these projects. So the question is, why is it so difficult to scale successful integrated care projects and transform the health system? There are so many nice pilots around their projects, and why can't we just use those and transform and scale up? Is it a lacking shared vision in the system? Is it maybe lacking leadership? Inadequate training? Missing financial incentives? Lacking evidence on quality and cost of such projects? I think that is an important one where we just ended with, actually. Lacking digital infrastructure, probably in some countries and jurisdictions that's definitely an issue. Or is it really also missing supportive national policies? From some work we did, I know that often the national policies or the lack of it is also a key blocker of integrated care. So even the simple fact, how can you make your financing sustainable, for example, if there is no avenue into the regular financing system? So, do we already have results? We have questions later. Are there results, Ed? This is interesting, missing supportive national policies. This was the question that we added at the very last, thinking maybe that's an important one. And it seems that we were quite right about that. But also lacking leadership, missing financial incentives, lacking digital infrastructure, lacking shared vision. Training, of course, as well. So I think this is going to be, a good lead into the next panel. So I would like to ask Miklos and Minister Sakwardi to join the stage, and also Jelka. You're here, Jelka Zeletel. You'll be moderating this mini session here, and then I'll be back also for the questions. So the floor is all yours now.
So it's really up to this panel to give a response to the most missing part. In JADECARE, actually, we studied how to make the results of this work live, that would be alive after this project ends, and so we studied the original good practices. And we found actually that 3 elements were really important, and one was appropriate policy environment, or let's say broader initiatives that also cover, what we discuss now, the digitally enabled integrated care. And we thought, or I thought, that it wouldn't be actually the point in our discussion today, but it has to be, obviously. So this would be first, let's say, a little part to reflect on from your countries. The second cornerstone was actually the holder of sustainability. So who takes the responsibility for longevity of the good results, or if the results are not good, but they are expected to be in the future years? So what are the processes? What could be the structures that could be supporting that? And the third one is a repetitive one. It is actually the culture of consensus seeking and communication. And you've heard from our next adopters, from our implementers, that they were really working hard to try to come to speak to those who are in charge of those initiatives and policies, And also we within Joint Action, of course, had quite a few actions to actually support it, but it was really found harder than we thought. So what would be your thoughts on that? Maybe if we go first to the Basque Country.
After viewing the results of the question, it's not easy to be the health minister of a country and try to translate you what we think. But anyway, good morning, everybody. I'm the health minister of a community of 2.1 people, and I think that's something important to say also, because when we are talking about good practices, we are talking about the whole community. Whole community means all those 2.1 million inhabitants in our public system. And I think that's important because we have to contextualize. Also, when we are talking about the challenges that we have now in the health services, it's important the moment we are living, where we are coming from in the very near past, which is the COVID-19, which has teaches us a lot of things, has forces us to take very quick decisions, but also has shown many things that were happening in our health systems and that actually we have to think about. I have to say that in the case of the Basque Country, and maybe that's one of the best things that we can share with all of you, is that we have tried to go in the both views. We have tried to go from the top-down decisions, because it is true that since 40 years ago, systems are slow because we have a lot of people to work through, and we have to keep doing our everyday duties, which are to take care of the person's health, no? And we were decided to have a new system of trying to serve our community in health issues and also working from down to a top decisions. No, I think both things are very important. I think that when we think about the politicians and how we decide to make our decisions, we think that they are living somewhere apart. And that's not true, at least in the case of the Basque Country. We try to stay very near to the population and very near to our professionals, because in the end, the person has to be the center of both of us, politicians and professionals also. And when you mentioned that sometimes it was difficult to talk to those in charge of policies, I have to say that sometimes we forget who are working for. We are not working for politicians. We are working for our people, our citizens. And we, when I say we, I say all the people, all the stakeholders, all the agents working around health systems. We have also to talk to our patients, to our citizens, because we think that we know everything about them. And health is something that belongs to each of the people who is attended by our services.
Thank you. Miklos, Hungarian, you have experiences from many levels. Please.
If you do not mind, I start with a comment of why we wanted to be part of JADECARE. And the reason was that we knew that it was Chronic Guna initiating it, and what we saw in their activities was that common sense emerging. Let's do research, look on the care journey as a whole, and use the pilots to scale up to policies. So we saw that emerging, so we wanted to be part of that initiative. And on our side, by the way, this is a very interesting natural experiment, because the Basque people in the southern countries are Spanish citizens, and in the Nordic countries they are French citizens. So there is a natural European experiment in approaching the provision of digital care and the development of digital care. So we should look at that. But what happened in our case, we had an experiment in the 2000 7, 8, and there they wanted to integrate the various data sets. We have a one-payer system, so we have information systems at the GP, outpatient hospital, the same stuff. But they only used it for payment purposes, not for patient journey management or patient management purposes. And all these, for data protection regulation reasons, these projects collapsed. And I said, come on, this cannot go on. So what we did is that in 2010 and 11, we just unified the system. So we set out a joint national e-health system. And if I take out my phone today and I open the health window application, it's just, sorry, I will show you all my health documents. And it's default, by default, for every citizen. So so that's it. And you just cannot imagine the power of it. As my wife, who is a GP, knows whether the patient did the prescription, what happened with him or her at the clinical care, so that you just cannot understand the power of it if you do not have it. And you know, the introduction of it did not happen that there was a new platform, the Estonian colleagues. It is not a new platform, but a new menu item in the hospital information, the GP information, just a new item. And then the window opened. So it was, and just one last bit, there was a debate whether we should go positive consent or negative consent. Mm-hmm. And what we told to the Hungarians and what we told to the patient associations and the rare diseases patients were demanding the general use of health data. And what we said, donate organs, and you know, in the Hungarian system, you are an organ donor up until you say no. Donor organ because you save lives, donor blood because you save lives. Donor data or share data because you save lives. So we use the negative consent principle, so it's a joint national platform. Now what we have to do is build applications on it.
Thank you really for these insights. In JADECARE we also did a natural experiment, and we actually helped all the implementing sites to develop the sustainability strategies and action plans. And actually we have them for all environments. And they are ranging really from being part, let's say, of the National Recovery and Resilience Plan in one big country in Europe. In another country that were not implementers, actually the individuals pushed towards developing the digital strategy for the huge country in Europe. I will not be mentioning the countries, but there is a potential huge impact also there. And in some countries, for example, they found out that the only way that they could go forward is that they themselves keep an eye on what is coming up for the future potential windows that will be opening. So how do you think that being the top-down and bottom-up healthcare system policymakers, how do you think that these windows of opportunity could really be visible to those who would be able to implement new solutions in Basque country, since you mentioned this top-down and bottom-up approach?
I think that the best example of it is shown results. And we have discovered, for instance, that working together, centered in the person with the social and health care systems, and developing tools, digital tools that make us share and conform all the history, medical history, social history of the needs of the people, show that the benefits are growing. And the people is getting a more personalized attention than the one we were previously offering. So I think that we have not only data, we have results that can be supported in evidence, and that can show that we can be more efficient. And when I am talking about more efficient, I am not only talking about money, which is important, because investment during the years has to be done, and that's a political decision. I know that, and we have tried to support them from the government for many years, but it's not that the most important thing. It's needed, of course. You can't do anything without it, but the results should be, if those results in better health of those people, in better response of the different stakeholders, we shouldn't forget that health is in every policy. And that's something essential also when we are talking about systems. We are not stand systems. We should be, and the experience has showed us, for instance, that cooperating with all the social system and cooperating and sharing our knowledge and sharing our data has becoming into a wellness in the people we are taking care of. We can prove that, and I think that's something that could be a good experience, of course. And I think that the colleague from Greece said that very well. There is no magical solution anywhere, but we can learn and then have to make our own approach.
Perfect, yeah. So windows of opportunities on one hand, and on the other hand, you have to, at the policy level, act, like that. You don't have 2 days to study the evidence. So isn't maybe there an approach where, let's say, science people and the policy people would better learn how actually to communicate? Would that be something, a skill mix that would be needed for better scale up of the results of such actions?
Definitely. And my understanding is that, at first, we have to understand that this is not a mobile app, and this is not a startup. This is a systems capability. And one thing is that you have the general frameworks for a unified system. Those people, Estonians, Basque Country, Hungary, many, Portugal, lucky we have it. But then you cannot live without bottom-up, because there's this pile of documents. And who does the clinical dashboards? It is the clinical partners. So there has to be a trust from the policy side to the clinician, to a hackathon that a university organizes for solutions, that you can bring these solutions on to enable the system, so the system's capability enlarges, because no government institution, no private entity would be able to develop the richness of that sense. And it's, and then this, the co-creation with patients. That's also an important stuff. So the digitally assisted care models should put the patients in the focus. So patient associations, medical associations should look for the most ergonomic solution that is saving money, saving lives, contributing to the balance in chronic conditions. So that should go hand in hand. So and then there is an issue whether the person in government understands the strategic importance of that. In Hungary now we are lucky, the minister understands that. But whether the EU funds could be aligned, whether the industrial lobbyist could divert, whether social care comes on board, because now there's an independent compassionate clock solution that is not integrated into the health solution. It's just a button you push to seek help. So it's a more complex stuff, and communication, change, integration should be coordinated skills of the individuals in government position. Then it comes to play.
Thank you.
You just allow me, I agree absolutely, and I want to pay a little bit more attention about trust. Yep. Trust. I think that we have many challenges nowadays in the health systems, the lack of professional, which is happening everywhere, the elderly population we have, the technology, which is going very fast, but we have to keep our professionals very well formed so that they can use them. We have to show our population what we are looking for. We have to be looking at the health system and social system in 40 years. So many challenges, but there is one that I think that is very risky one nowadays: trust of the population. And it's not only the lack of trust in the politicians. I think that in some way it's the lack of trust in our professionals, because we keep trying to show how many are the challenges, and we keep demanding more and more, and we don't see, I think so at least, that we are showing the society, showing the population that we are not in the center of the object, which is taking care of them. There is a need of a little bit of more, maybe, communication inside, a multi-governance new models, which are demanding the young professionals, and also a little bit of getting trust into our own capacities that we have, because, for instance, the Basque Country public health system is a very good one. I really think that. I'm not saying that because I am the Minister of Health. I believe on that. That's my only health system. I have no private systems. But we have to make it participated by our patients, by our citizens, and getting back the trust they had in the system and also in the professionals. And those are the only ones that can help us to do that. Whatever I may say won't be trusted by population if it's not with the everyday work of our professionals. And I think that can be risky, especially when we are talking about public systems.
Miklos, you wanted to come back to the trust issue?
And on two levels. Number one is cybersecurity. So we can ruin the thing if we have attacks. So cybersecurity is an issue, and we will even more issue. And that leads me to another trust issue on the European policy level. You know, pre-2018, Germany and France, and I understand Gestapo, Stasi, French Revolution, civil rights. So I understand the cultural and political consequences of that. And you know, there was the Estonian presidency where the informal ministerial meeting, the password of the Wi-Fi network was liberate the data. So the Estonians made a trick. And that's when the Germans sort of officially converted, data is available, GDPR is there, so let's have a path to secondary utilization of health data. But you know, again, that's a trust. How can we gain trust in countries where the culture, political culture, does not necessarily support these solutions? But we are sharing on social media and the banks and all that stuff. We're sharing more information than in health. More people die, I think, because of the lack of consent than as a consequence of sharing their health data. So I think on European level, we should give trust for investments that are going into the coalition of willing. So those who are willing to do the best cases and the use cases, best practices and use cases, those should receive investment and use them as a living experiment to scale it up to European policy level.
And I think that should be also with regulatory development.
Fully agree.
We need
Fully
them.
agree. Fully
because
agree.
if we have the trust of the population, there will be no problem with those people to share the information. But we have two problems. One, you said, maybe financial, but another one, regulatory.
Yeah.
And I think that's something that the European Commission can help us on. That's where I see that all the European organizations can do a very, very good work. And I have to ask that we are a region, we are not a state, but we are developing our own health systems. Regions have to be on the European discussion.
So European Commission started the health program with the JADECARE, who obviously responded to the needs of the European countries. We have had really a lot of extensive meetings, and the results are marvelous. We covered more than 4 million people with JADECARE activities. We have at least good intentions in the frame of sustainability strategies and sustainability action plans, and you see that the policy level is not just something that we found out during JADECARE, but it goes beyond and comes again to the European Commission and our common environment and common world with trust, but without pink glasses. So we have to think of the vested interest. So maybe now the time, with your help, for questions to audience.
I can help. Are there questions here for the panelists? I think you had a question.
Stefan Tomek again. Yesterday we had in a meeting with the Minister of Austria of Health, we had the conclusion that one of the reasons, the most important reason about the lack of transformation of the health system is that so many crises came so that the classical medical sector doesn't work, with waiting lists all over if you have to go into hospital. Plus the transformation which is necessary to transform our society and system into a preventive medical system, which was, for example, presented by us at the in Davos 2020 as a UNESCO claimed for help against the pandemic obesity, which the WHO in 1819 already as pandemic positioned. That we can only succeed if the big decision makers in economy and in politics, national and international, plus the EU, build a public-private partnership for transformation. Otherwise, with the coming up of the health crisis through the climate change, through the lack of immune systems working, etc., viruses, increase of cancer with 20% per year, we cannot succeed. So this is my question now. Do you think that this position we worked out yesterday with the Health Minister of Austria could be a solution? Could you imagine that we can succeed with such a big effort?
Would you like to take the question?
Of course, the more we share and the more we go together, we will be healthier. And we will be more, maybe, decisory in big decisions. But I think that the context is very important. And we don't have to be so dramatic, and we have to be more realistic, because changes come from everyday's life. So in the meantime, we have to continue working. That's one point. Second, we can always be asking higher and higher levels to change and transform. And I think that we are losing time. That should be okay, of course, and we will be ready to contribute, to stay, but we have to work every day. And as small as I can be as a region, I have to do my part. And in that responsibility is not only the responsibility of the politicians, because I can decide about the investment in my own region. I am lucky about that. And I don't have to convince my president because I get the money I need. Being public, that you know that we have to take very good care of the finances because it's everybody's money. But transforming the system means that everybody has to understand that. I can have the best digital systems, those are tools. If the patients don't understand that, if the professionals don't understand that, and if the politicians are not in the same clue, we are going nowhere. And we will fail. Even if we have the highest consensus, the highest one, we will lose that. And I agree, many crises that we are living, and the health system is having a quick answer, and it's getting tired. So let's think about that also, because we are part of it, and we are demanding and demanding and demanding. We have to know that we are going to be part of that possible crisis.
Also, Miklos wanted to come in here.
Just a quick answer in the scope of this session. So if there was a anti-obesity program and everybody, citizens, professionals, government would be on board, the Hungarian digital healthcare system could support you with the information how many megatons Hungarians lose in body weight in each day or month. So the digital solutions help in those programs. My other answer, in Hungary we introduced public health product tax back in 2011. Yes, we were taxing Coca-Cola and chips. This was not an easy thing, and the most difficult negotiating partner was EU. We ruled out trans fat. You know, we could not have a label on food that it contains wrong trans fat, because that was, that's anti-competition, said the EU. So the most difficult partner in that game was the EU. And it would have been much more easy to target the public health product tax and all that stuff. So I think EU should come on board. And just as you cannot do cessation programs with tobacco companies, public partner partnership with tobacco companies who are interested in addiction, sugar companies interested in addiction. So you cannot do it in a PPP. We should regulate on European level and assist the exposed member states.
Okay, I know there's also a question, well, first in the back there. Was first, and then we'll come to you. And I also want to go, of course, to the online participants, and then we have to wrap up, actually, because then we are nearing our time. Go ahead.
Yeah, morning everyone. Usman Khan, KU Leuven. Really interesting discussion this morning. Thank you for that. I just wanted to give an example. I had an MRI. I'm based in the UK, and I had an MRI. I got a letter telling me to come to the MRI. I then got a prompt on my phone reminding me to go for my MRI. When I arrived, I had to fill in a piece of paper by hand to be able to show that I was clear to be able to have the MRI. When I got the results, I got a digital response from my clinician saying the MRI had cleared me for whatever I was in for. But what I hadn't got was the MRI. I wasn't sent it, nor was I given the opportunity to be able to ask further questions about what that MRI might have had. So what I'm saying is there are elements of the care that were digital, and there were elements of the care that were integrated, but what I didn't see is that they were not person-centered. They weren't centered on me as a patient. So I'd like to see if you want to make comment in terms of the developments you're seeing on the ground, and are you seeing that connectedness and that real person-centered care?
Okay, we're going to collect another question over here in the middle.
Hello, my name is Elisabeth Campestrini, Health for All. Access to health is a human right. We work with countries in transition, and we're very pleased, or I'm very pleased to hear your comments. This is very interesting, and I shortly introduce, we work in health system development in Kosovo, focusing on the health of youth and mothers and children. And digitalization is a very important part of our aspect that we are trying to achieve there. The question I'm having now is regarding, first of all, Minister, thank you very much for raising the topic of trust, which I think is really essential. And before has been raised the issue of need and capabilities. And I think most of these issues are very, very important. And I want to add two questions in this regard. Question number one, health literacy and digital literacy, especially in rural areas. How do you deal with this? What's the issue in this regard? And clearly also capacity building is very important. Capacity building, are you involving this capacity building aspect, even though it's a mid-term and long-term perspective, of course, for health professionals, but maybe also in schools, kindergartens, etc. Thank you.
Shall we take one more question in the back? And that's then the last question we're taking here. Keep it short, please. Over there.
Jan Willem from Philips. I can send you that MRI report if you like. I was going to ask about the European health data space. Both of you mentioned that you have a local system, that some of the support you need for regulation is at the European Commission level, but there are differences in culture between the countries that will allow you to only go that far. So do you feel that some of the problems you have in data sharing and anonymizing and secondary use are going to be solved in the European health data space, or do you believe that you have the coalition of the willing at the sub-EU level that are going to forge ahead despite the shortcomings of the European health data space?
Also a very relevant question. You can pick which one you want to answer. Maybe you could answer the one.
The one on the European data
Please
space.
go ahead and then
So generally the project is out there, of course, and the initiative is very, very much needed and valued also among our partners. But what we can say from JADECARE experience is that it at the end comes to day-to-day changes and day-to-day transformation in what and how we work. And for example, Christina has really said in a few sentences that also her own mindset has changed during JADECARE, because at first she thought very clearly, sincerely, that they would be just taking a piece of something from another practice and use it. But now she knows that it's really much more needed to be contextualized, and that you need proper understanding of needs and the feasibility, actually, what you decide to work on. And to just repeat again, you need the right people on board and the right stakeholders on board. So the European common data space is a good idea and a good goal to approach to, but the path towards there should be contextualized.
Okay, Miklos, you wanted to come.
On the health data space, I have a very paradoxical position. I'm so happy that secondary utilization is given way, but on the other hand, the way the regulation looks today, I advise the Hungarian government to act very cautiously, because one of the results is that the data-rich system capabilities countries' data would be sharked on by the tech company owner data-poor countries. So, and I think that should be prevented, and there should be more room given for this coalition of willing to develop their systems capabilities. That's a very strong message on the coming AI Act too. And I would be very active in the coming months to correct this. And the other stuff is Usman's comment, this is for patients and the caregivers. So if the person is left out of it, then there is no reason to develop into that direction. And literacy, I fully agree. Literacy, the lack of literacy will contribute to opening the gap between the illiterate and the one with the literacy. Social determinants of health would be larger. I agree.
It does need special attention. Would you like to come in, or would you perhaps take the question?
Just a little bit to go on with literacy is one of the challenges, of course, and we've got it very clear, because in the fundamentals, in the values, is where we have to be very aligned, and equity in a public service has to take care very much on that. When we are talking about literacy, health literacy, for instance, we had an experience, and it is in the project, in JADECARE project, which we call Osasun Eskola, which means health school, where we tried with our professionals to make that gap reduce. And in terms of digital literacy, it exists, but it's not only for the age, it can be for economical reasons, it can be because where you are living, this is the rural areas, and that's where I think that the saying that health is in every politics should be showing that, because we have not only to look to the health ministers, but we have to make it work as very priority in all the policies that we are developing in our different governments. That's something that at least I've got it very clear, and now that we are working on the public health law in the Basque Country, we are trying to impress on that.
Okay, I'm trying to wrap up now. Were there similar questions from the online audience, or is there something
Well, there was one question related
Let's do one question and then
to the
we'll
view on the
wrap up
EHDS. So I think the colleagues responded already, how the EHDS can help, digital across Europe. And the second one, maybe, what's next for JADECARE? JADECARE 2.0, a network of the willing.
Shall I pose that question to the leaders, the coordinators, Anna and Yasmin? Perfect bridge. Thank you very much.
Thank you. Then maybe I can stand here. So I'm not going to repeat anything because I think that we already have heard a lot about the insights and experiences and the challenges of JADECARE Joint Action. But I must say that even if we have quite a lot of challenges when we are talking about these large-scale implementations in Europe, it is doable when we have this mandate from the Commission to just take one good practice from one place to another one. That's impossible. We need to adapt. And we have like 21 adopters with very heterogeneous contexts, with the maturity level of integrated care really, really different, but we managed to do really good implementations in several aspects. So my message is that it is doable, and we hope, we believe that JADECARE can inspire others in this transformation of healthcare system towards this digitally enabled patient-centered care. And JADECARE 2.0, I don't know. This question, I think that should be directly go to the European Commission, not to us. But we will be ready here for JADECARE 2.0.
Well, that's good to know. Yasmin, did you want to? Yeah.
No, just wanted to add maybe on the sense of this JADECARE 2.0, whereas it is true that maybe for the Commission we have not received this, let's say, additional mandate or funding or whatever. All the sustainability, yeah, sure. All the sustainability work that we've been here and that has been produced during JADECARE, particularly all the implementers and next adopters have been really working on building these sustainability strategies and action plans, also specifically designed according to their own needs, to their own, let's say, resources, so that this will make it possible for the local pilots to continue later and beyond JADECARE.
Fantastic. I'm very much in favor of JADECARE 2.0. I think, Miklos, you wanted to make one final, very short, last 10-second.
That's for the Commission people. Let the JADECARE people, yeah, of course, look on the accounting, whether it's transparent, it's fair, but let them not write a final report, but write a policy report that could be investment criteria for future Commission investments in digitally assisted care. Yeah.
Well, there you have another.
I want my last word, please.
Yes, of course.
I agree with you, but don't forget something which is most important for me. Persons. We are talking about persons, and there is a risk about the digitalization, and is that they don't understand what we are saying about health digital systems. They may think that we want to supply the person taking care of the person. This is the doctor, this is the nurse, this is the psychologist, all those people who work on health. We are not talking about that. I think you have done a great work on that, trying to focus the persons in the city in the center of the solutions. You continue like that, please. Don't forget it, because that could be also a big risk.
I think that is a very nice note to finish with. I would like to really thank Miklos, Minister Sagawadi, Jelga for moderating, and of course congratulate the JADECARE Consortium. Thank you for the moderation of the chat, and I hope to see you in a couple of years with JADECARE 2.0. Thank you.